it will most probably settle your tachycardia. But if it still does not settle, then I will have to go with some medicines which I might need to give you.
Okay, so do you think the patient will understand vagal maneuver if you explain to her? Or any patient came up to you and you say, I will do vagal maneuver, how would you explain to the patient in simple words what mean your step would be? Okay, no problem. I'm going to explain you what you will say. Based on your information, the most likely problem in your heart electrical activity, okay, you will say like that. What I'm going to do, I'm going to move you to research room, connect you to the monitor, check your vitals that you're okay, do examination of your heart and lung sounds, and then I will do some tests, and also it includes full blood counts, heart racing. Okay, if it's confirmed there is a problem, which I am thinking it's SVT, so I will treat you with a procedure called vagal maneuver. The vagal maneuver, but I can make it simple for you. That means, first of all, you will be in sitting position. Your bed will be up to 45 or more and around 7 semi-recumbent position, I think we say. Then I will give you a 10 ml syringe. You will blow, okay? After blow, okay? Then I will bring your bed down and raise your leg up to 90 degrees or raise your leg from the hip. And while doing so for a few seconds, I will check your heart tracing again and make sure, check on the check the monitor to make sure that it's resolved. In case, if not successful, I will give you a drug, a medicine called adenosine 6-mg. Okay, so you need to make vagal maneuver have two types, right? Well, Valsalva maneuver and also carotid massage. So what I explained to you is Valsalva maneuver. It's type of vagal maneuver. So you first need to make the bed up, the sitting position. Then you need to ask the patient to blow the syringe 10 ml. And after that, you need to put down the bed in flat, supine position, then leg the raise the patient up. I'm going to show you, just give me 1 second. Can you see that?
Yes, doctor.
Yes.
So don't need to say like, I will do Valsalva maneuver. Patient doesn't understand what you say, right? Another thing, the patient, if he has or she has SVT, maybe she knows these about the vagal maneuver, etc. More likely, patient will tell you she knows that she has a similar episode before many things. But if WPW come up, so you need to change the management plan. Got it, guys? It's very rare to come up this station, but you should know about it. Most common in thyrotoxic cases. Okay, clear so far, right? The management plan is okay. Did you got it, right?
Yes.
Just
What will we change in WBW?
WPW, you need to refer this patient. What you can do, you need to refer to the cardiologist, right? You don't have right to manage this patient. It's serious. The management plan for the emergency SVT or these other things, you can do it. But for WPW, you need to refer this patient to cardiologist. Okay? And it's very rare to come up in the exam. And most likely the station you will have, which is relevant to EM, okay, ED, which you can do something, not like every patient you refer. So This is not your specialty like cardiologist, so that's why I say so. More likely you will have SVT, but from history you can get it. The most common which came up already in exam is thyrotoxicosis. Okay. The next one we have AFib. Okay. Sorry. Anybody can tell me how to treat the atrial fibrillation? Hello? Can someone tell me? Atrial fibrillation?
First rate control, then rhythm control.
Okay.
It
Okay.
depends if the patient has a
Yeah, there are the three types of AFib: paroxysmal, persistent, and permanent. So depends what you have. If it is greater, if it is in 7 days, in a week, then it's called paroxysmal. But if more than 7 days, that means it's persistent, and permanent cannot be. It's longer term. So more likely, maybe in the EG, you will have likely the patient with paroxysmal, not the permanent one. In case you have permanent, you need to explain the treatment plan to the patient, then refer to cardiologist. Okay. Next is ventricular tachycardia, more common in the elderly patient, particularly those with ischemic heart disease. So if the patient is systemic stable, I mean, are not unstable, how you will treat this ventricular tachycardia, guys?
First of all, we have to take the stability in the consideration. If the patient is vastly stable and there is no signs of failure, there is no ischemic cardiac discomfort, there is no syncope, then we have to wait for the rhythm. And if the rhythm is, we have to wait for the rhythm. And we have to do the only the ECG monitoring and check the electrolyte imbalance and admit the patient for any instability. If the patient has the signs of instability, that is the ischemic cardiac failure, shock, and in syncope and the failure, then we have to treat the patient. And for that, pulseless ventricular tachycardia, we have to give the 3 shocks, shock and CPR, shock and CPR, shock and CPR. After the 2 shocks, we have to give the amiodarone. Yeah.
Thank you. Yeah, this shock we'll discuss in ALS. Good, very good. Good try. The unstable patient you will manage with amiodarone, okay? Got it?
Yes, sir. Yes, sir. Yes, sir.
The stable patient, isn't it?
Oh, sorry. Stable, stable, not unstable. I'm talking. Yeah. Stable patient with amiodarone. Okay, so this was the last ventricular tachycardia. I think we have one more bit. Just give me 1 second. I cannot go down. Oh, no. No more, yeah. Okay, so this was about the thyrotoxicosis management. I teach the nice guideline, so you need to follow it, okay? You just need to explain this type of treatment and refer to endocrinologist for further. But you need to simplify what's meant by radioactive iodine in your own words, okay? You can find out. And this is a Waltz-Lewis maneuver, which is type of Waggle maneuver. Carotid massage also is type, okay? You can explain carotid massage or this one, both are the same. Okay, so next is our patient will be present to you SOB. So this condition, possible patient may have it, okay? The common is asthma and pneumonia, which is very common for the exam in your case. Okay, so asthma patient wheeze, cough, breathlessness, seasonal variation, maybe he will present to you, triggers that make symptoms worse. So who can try to tell me, okay, you found the patient has asthma. Now what you will do, guys, after that, how you will explain him to your management plan?
For the asthma, we have to classify the asthma. Either it is a mild, moderate, severe, life-threatening. And for that, we have to consider the signs and symptoms along with the respiratory failure and
Okay.
signs.
Just
So
I want to tell you, okay, you found the asthma, patient has it. How would you, for example, I'm patient and you or the ED physician. Now you found that I have asthma, what you will do next?
we have to do first the peak
No.
expiratory flow rate.
Talk to me like based on your information, like go for management plan that people can catch your point also, yeah. Based on your information.
Based on your information, the most likely problem is in your lung.
Management depend upon the severity of the patient.
I know.
I will take the patient.
Oh,
I will
okay.
take the patient to the
Based on the information, I think it might be an attack of asthma. So in order to do the treatment, I need to get some quick examinations, and I need to do some investigations also. And I need for the treatment, I need to grade it. I need to grade it also. So I'll be doing one test is called fractional exhaled nitric oxide, and is spirometry as well as is peak flow variability. After that, I'll be deciding the grade of your current symptom, and if it is and I'll be beginning some medication through the
Okay.
nebulized. Yeah.
Okay, thank you. Okay, I'm coming up to that. Okay. Okay, for example, you're a patient, you have asthma. So you're adult, you should have asthma, not the first time, you should have many time already, right? So come up, your means diagnosed, right? Now is exacerbate or what else, you come up to me. I will say, based on your information, the most likely problem you have asthma or the worsening condition of asthma, what else you say? What I'm going to do, I am going to move you to research room. Okay, I will check. I will use a tool to grade your asthma. First of all, I will connect you to the monitor. Okay, if I found it's acute, how you will know acute? If I found your heart rate is greater than 110, 130, yeah. 110, and your respiratory rate is greater than 25, that means it's severe, okay, form of asthma you're having. And other than that, I will also use one equipment. I will ask you to blow. That's called to check your peak expiratory flow. If I found that it is less than 50%, and you have these symptoms, heart rate greater than that, its condition, that means you're in severe form. What I will do after that, I will give you the medication through a oxygen-driven nebulizer, means I will attach your nebulizer and I will add the drug in it called salbutamol. I'll let you breathe. Okay, if after if I found that finished nebulizing, after nebulizing you, if I found that your condition is improved and your peak expiratory flow rate is more than 50%, I will discharge you with printed leaflet and arrange a follow-up with your GP. Got it, guys? One is this way. The other way is you just say, I will use equipment called peak expiratory flow rate if it is greater than 50% or less than 33%. That means it's severe. And I will check further, do examination of your body to check cyanosis, explain what else condition included in heart rate, respiratory rate. If I found that you're unstable in these things, then I will nebulize you, and then if you found still condition not improved, then I will add another drug called ipratropium. Means you need to go further management plan. In case you said, if I found life-threatening, which is very severe, in this case, I will admit you under ICU team. Like this way, you need to explain. Got it, guys? But for you in ED, you will have maybe moderate or maybe the acute severe for ED, okay? Less likely you will have life-threatening because patient will be in ED, you're taking history, so I don't think so. They will give you very complex. Okay, clear so far,
So
guys?
So I have a doubt. In every asthma, should we take them to resuscitation room before examination?
For example, if patient came to you in the ED for a short of breath, okay, he said, I have short of breath, but he sit in front of you, you say that. And now you don't know the reason why patient is short of breath. This all history you took it, you know now the patient has asthma. So you move to the resus room, that makes sense. But for example, if we go for another like chest pain, people say sometime, okay, are you going to move you to resus room? Maybe patient is not in a pain. Maybe he has in last night. You never know, right? Okay, even the patient in a chest pain, but is it necessary you need to attach the oxygen to the patient? Maybe he has acute pericarditis, maybe simple condition, maybe not really, not every patient you rush to the resus room. You can go to the resus room after you make sure that what is the diagnosis, right? You know this patient has asthma, yes, it's need to move to the resus room. You need to give the oxygen with nebulized driven, so this way you can go with it. In my opinion, what I follow, different people are different opinion, but I think it would be better if you go after they confirm the suspected diagnosis, okay? Because we cannot confirm with the, still we are going to do the investigation, but what you suspect. So what we make the diagnosis with the patient is always a presumption, which we can say the not confirmed diagnosis, right? So this way, I would feel better if I go in the end, not in the beginning or when I know the patient can present in complaint. How's it sound to you?
Okay, sir.
Thank you, sir. I have a query, sir. May I ask? In the management of asthma, we have to go for ABGs for confirmation of the PaSO2 level and the PaO2 level?
No, you, as I said, you just need to go to explain peak expiry flow rate. That's it. Got it. If this is clearly mentioned, if you did 33 to 50%, you say, I will go for that. If I found is greater than 50%, I will, you don't have to nothing, but what you have to do for, according to British Thoracic Society guideline, you need to give him salbutamol, but puff, one puff, and then you wait. If patient condition improve, good to discharge. If not, then you give every 1 second maximum 10 puff of the salbutamol. This is how you can explain to him. But if you find the severe, then you have to go for salbutamol nebulized driven, okay, oxygen driven, not like the puff you have to use. Got it. So this is oxygen driven here. If this condition, you need to give puff without oxygen. Got it, guys?
So one small query, like how you said, we have explained in very simple terms to the patient, like we'll be measuring the PFR using the tool and everything. Now, since we do not know the value, do we explain about all the causes, like all the grades? Like if you suppose PFR comes like more than 50, it will be moderate. So we'll be treating in such a way. And if it is, 33 to 50, or do we just say, we'll just measure the PFR and see how it comes and then accordingly manage you accordingly? Or do we just give all the options before itself?
If you have very less time, but believe me, you will have a lot of time. Why RCM increase from 6 minutes to 8 minutes inside the station? That's the reason that they don't want to give you or give us excuses like, oh, the time was very less, I couldn't explain very well management plan. No, the RCM divides your syllabus the way it's very, very important. the first step you pass like basic, intermediate, clinical. Now in the third step, you need to apply your clinical knowledge, right? If you just say accordingly, means that's everyone can say. If I someone to say, okay, you just memorize, and if you find asthma, okay, I will treat it accordingly. No, you need to simplify it. Tell the management plan to patient that what you are going to do. That's why the 50% or the even 35% you get a score from the management plan. History taking is not a big deal. If you take it, if you diagnose the last three portion, like diagnosis and the management, are very, very important. Okay, so this is
Okay, thank you, sir. So the more we explain in detail, the better.
Better to explain. Get more score. Don't leave even 1 point. Okay.
Okay, thank you so much.
Okay, next is we have pneumonia. So it's clear for guys asthma, you need to follow British Society guideline. I will find out some algorithm. If I could, I will send it to you in the group and you can check it. You can download directly from British Thoracic Society. Just Google it, you will find out. Okay, next is pneumonia we have. This can come up to you in the exam. So this is also very commonly tackled in the ED, in the A and E, so it's likely to come. So the cough and dyspnea, sputum production, when patients say yes, he has some sputum coming up, so you need to ask the color. Okay, the white one or the green or yellow one, so you can know what could be the cause. The pleural pain can be have patients sweating, fever, shivering, etc. So how you will manage this patient, guys? Now management plan, anybody can tell me about this management plan for this patient. I am your patient.
So I will take patient to resuscitation room because patient have shortness of breath and cough. Then I will take your vital signs and I will take blood test, including a full blood count, urine, and electrolyte, and also I will take VBG, and if needed, I can take blood culture. So this patient, I will treat it according to something called CARE 65.
Yes.
That one, it will classify our pneumonia. If the patient, we will admit, or either we will discharge or admission in the normal ward or in ICU. So according to our CARE 65, it came one. So I will discharge you with oral antibiotic and you will go home. If it is two, the patient will admit in medical ward and he will receive IV antibiotic or oral according to the patient's situation. If more than three, so patient, I will admit you. You will go for ICU admission and under care of medical doctor.
Excellent.
Yes.
Great. Yes, you need to follow the curve score, curve 65, C or B 65. I think it is one more score, but which we use for community setting, which is good for GPs, not for us. Okay. So curve 65, we urea C confusion, urea greater than 7. So this is score. And the score 0 to 1 means low severity. Consider outpatient treatment and antibiotic. 2, consider for short stay in patient treatment. 3 and 5, arrange a critical ICU admission. Okay, so what is the antibiotic first line for this patient, guys?
Amoxicillin.
Amoxicillin.
Yes.
Amoxicillin.
If allergic, we will go. Okay, good. Yes.
Mild or moderate or severe.
According to the patient have any allergy from amoxicillin, no. If patient, best to give an amoxicillin as a first line, but if not, if he's allergic, we can give patient clarithromycin.
Okay, thank you. Yeah, okay. You
Okay.
guys know it, but I want to go a little quick, okay? Because we have so many things to do. Still, we have many tables behind. Okay, tuberculosis. So we have the patient would be short of breath, cough, the blood or mucus, anything you will find in the history. Once you got it, what you will do now, guys? You need to either to TB specialist, you need to send him, but you need to explain the management plan. Yeah. I'm talking about pulmonary here.
Yes, we will take, first of all, as you mentioned, we will take the history, and after that we have to do a specific test for in order to diagnose the case. Like we have to do full blood count and ESR to know about what is the active stage of the disease.
Okay.
And then we have to do a chest X-ray to diagnose whether it is a tuberculosis or whether it is something else.
Okay.
And
so yeah, very good. Okay, so let's come up. Okay, you knew it's tuberculosis, and you need to explain the investigation. Okay, first you will say I will research room or observation room, connect to oxygen if require anything. The investigation you will say mento test. Okay, the sputum culture, chest X-ray.
Gene
Okay. So, yeah, gastric lavage, these all things if you do. And then the management plan, you just tell him, but tell him and then refer him to the TB specialist for follow-up. What the treatment plan for this patient would be, the isoniazid with paradoxine.
We have a two-stage treatment protocol for
Yes.
tuberculosis.
Yes.
Initiation phase and then the continuation. Initially, the continuation, we have 4 drugs.
Okay.
Isoniazid, rifampicins, and pyrazinamide and ethambutol. And then for the first 2 months, and then we have to manage these 2 drugs. The 2 drugs will be excluded, and we have to put the patient on 2 drugs. Along with these 2 drugs, we have to put the patient on vitamin B6.
Yeah, so the first 4 drugs we have to give, okay, the isoniazid with paradoxine, ethambutol, paradoxinamide, I think. One more is rifampicin. Yeah, rifampicin. And then 2 drugs, isoniazid with the paradoxine plus rifampicin. Okay, this is a treatment plan. You just need to tell him, and then you refer to him to TB specialist with follow-up. Okay, this is your job to do. Okay, so next.
No need of isolation in the
this is come up with the advices what you have to take it. Okay, I mean the isolation, why you should move to the isolation room at the same time.
Yes,
you suspect, but not really. So you can say either research room or isolation. Yeah, you can aid it. Yeah, it's a good point, I think. It is good. But if you have suspicion, you are not confirmed, but you can say in advice it's confirmed, then in advice you can aid it. The isolation, you need to tell him to avoid following activity, to avoid this till your condition going better. And also about the treatment, you need to check your weight is gaining or not, if symptoms improve or not, with follow-up with the TB specialist. That's why I aid the TB specialist, because few things he will learn from there. Okay.
Yes.
Okay. Now let's move to the
isolation. Isolation is usually required in culture positive patients.
Yes.
If the patient is culture negative for the food, then the patient didn't need any isolations.
Correct. So the lungs cancer we have right now, lungs cancer, you just need to give symptomatic treatment like the short of breath, you give oxygen. If a patient has developed pneumonia, pulmonary edema, you need to treat that one with the diuretic, etc. And then you need to refer this patient to oncology. I don't think so you will get in the exam, but I just put in because we are discussing ICOB and the cough. The next one, we have the pulmonary embolism. So how you will, okay, you suspect pulmonary embolism. Now, what you will say to the patient? Management plan.
If the patient, we suspect that it is pulmonary embolism, again, we have to look for the X-ray, ACG, and after that, we have to do CTPA to diagnose the case. And as you mentioned, we already know about the history, what is the history of the patients, which may lead to pulmonary embolism. We have to keep that point in mind.
Okay, you got the information from patient about you suspect pulmonary embolism, but you don't know how far it goes. So you need to tell him that we have a special criteria, okay? Or you can say screening tool called Wells score, right?
Wells score,
Yeah.
Wells score.
If
More than 4.
Yeah, if your is 4, less than 4, you need to explain what test you will do first, okay? If it is greater than 4, then what test or what step you will take it. And you know, the most common cause of pulmonary embolism is emboli, which usually come from DVT, right? Then you will arrange an appointment with the vascular surgeon, right? Right?
Yes, you are right.
So you need to go for this kind of thing. I'm going to show you the nice guideline. You can check it out. So this is this is Wells score. If you are good enough in memory, maybe you can get it from the history. You can guess what the score could be. So you see, these 2 points are very important. 3, 3, 3. And 6. So if you got any one of that, means 3. So more likely would be the more than 4. Okay, means other point. You can add, like, if he has a cough of coughing of blood 1 and 4, this is 4. So one more, maybe patient has tachycardia. If you just need to explain, if from history, maybe you can get it if patient has all matching, but if not, then you need to explain if your score is 4 or greater than 4, I will follow this steps, means CTPA I will do. If I found it, I will give you the treatment called anticoagulant or direct anticoagulant, right? Factor 10 inhibitor, I think, or apixaban, rivaroxaban, I think. So this is first line in this patient. So you need to give, and then you need to arrange a follow-up with the vascular surgeon, okay? So this is how you can go for the steps for the treatment. Okay, clear?
Yes.
Okay.
Thank you.
You're welcome, guys. Okay. The next is we have pulmonary edema. I think this is not very difficult. Okay. So what is the management for pulmonary edema? Due to lung cancer, can be lung congestion, can be developed due to many causes. The lung disease can be due to the cardiovascular problem. Okay, so how would you treat?
We have to take the patient to the research and start the oxygen. Then we have to give the patient nitrates so that their preload should be decreased. Then we have to give the diuretics so that the afterload decreases. And then we have to give the positive NIVE, non-invasive ventilation, if the patient condition is worsening and the metabolic acidosis or the respiratory problems get worsens. Then we have to give the non-invasive ventilation. If the patient went into the failure, then we have to give the vasopressor, that is the dobutamine, along with the diuretics.
Excellent. Okay, so this you guys know, so you need to keep him in the research room to lift up his bat about around to greater than 45 to around 70, I think 65 degree, less than 90 anyway. Then you need to test the oxygen records, and also you need to go for the GTN, and all if it's hypertensive, then nitroprusside. The other, like furosemide, we have to give, means symptomatic treatment, okay, and treat the underlying cause, what is caused.
one thing is very important. If the patient is hypotensive and the systolic
Yes.
BP is less than 9,
Yes,
then we have to be careful in giving the nitrates to the patient.
Yes, that's correct. Okay, so next we have all pulmonary edema. I think nothing like. Oh, most important. I think in the previous SBA around 2-3 question came up from here. I think this is very important, but this is important. Yeah, this is important, but I think you will not have in ED. Maybe the patient is already diagnosed HIV. Okay, from the history you will get it. Patient will tell you, I had this, and you will say the patient has this pneumonia. So could you please tell me what is the treatment for this condition?
This is the sulfamethoxam and trimethoprim.
Okay. Co-trimoxazole? Yes. Okay, good.
Co-trimoxazole.
Yeah, that is the treatment. Good, guys. Thank you. So next we are moving to, okay, we are done.
Can I ask one question in this pneumocystis jirovecii?
Yes.
If the patient is allergic to Ciptran, then what we have to give to the patient? This drug is basically out of fashion due to this allergic reaction.
Not everyone, the patient, will develop this allergy, but you just need to verbalize that actually this patient should be already followed up with HIV clinic, right? Not necessarily should come to the ED. So very less likely you need to go for this patient with means you can say the allergic. Yeah, I think there is methotrexate. I think one more drug. I don't remember exactly. I'm sorry.
Okay. I myself don't know about the second line drug.
I will aid it in the group. Okay, I will check in the notes.
Thank you very much.
Yeah.
I think it is doxycycline, sir.
Doxycycline. No. I will. We will have break for 10 minutes later on. Then that time I will pick up for a few things for you. Okay. We will coming up to that. But anyway, if this is not very common in ED and less likely to come, I just added because you should know about this condition, that you don't have to worry. Then you think, oh, what's going on? Because this all are relevant, right? Now, as we have now visual disturbance, there are many conditions cause the visual disturbance. And this optic neuritis came, I think, in a previous exam, but not this way. It was in, someone told me it was in eye examination. So this is in history, less likely, but you should know, okay? Okay, so we're coming up to giant cell arthritis, okay? So anybody can tell me about that? What is the treatment? Patient will present to you vision loss.
It is steroid, sir.
Yeah, steroid. Last time we discussed about this, so it's steroid. So the patient will coming up to this condition, like he will say loss of vision, but when you take history, he will tell you, oh yeah, I have scalp hair, tenderness around my head, etc. So many things, okay? So you will give
same day ophthalmology reference.
Yes, that's correct. Then you will refer to him ophthalmology to prevent the eye vision loss. Okay, next condition, optic neuritis. This is very, very common with the multiple sclerosis. So what it could be the treatment for that, guys?
For the multiple sclerosis associated with optic neuritis, it is again steroids.
Yeah, we do give steroid as well. Yeah, and IVIG for optic neuritis. Okay, so IVIG we give immunoglobulin and also the steroid. But if it's usually we need to tell the patient it usually goes on its own 6 months, means the condition will be improved. If the relapse of the multiple sclerosis, we need to refer to this patient. Okay, and I don't think so you will have in the history taking, but very likely you will have in the examination. Patient will say, oh, I feel like color or disturbed, I have eye pain. If these symptoms come up to you, you need to think about optic neuritis. Okay, so next is, and very strange things happen to one of my colleagues in this examination. in the UK, London died. He said he did the examination, he did the fundoscopy, but usually they give a picture, right? The picture that what you find in the fundoscopy. And when he asked this picture, they said him, we don't have. You did fundoscopy, you should know about it. And then, of course, the patient told her that she has a problem like this kind of, she cannot see, she cannot read the color, etc. She said particularly red and some other color, she said. So the examination of fundoscopy often normal, right? So that's why the examiner didn't give them the picture. He just say, so he said, we don't have picture. That means you need to give the management plan what else you want to take this step for her. Steroids, you need to give her IVIG if necessary, or you need to tell her, the patient, that it will goes on its own within, or it will improve within 6 months of period. If not improve, you can come back, okay? Well, okay, so next is we have central retinal artery or vein occlusion. It's also less likely you will get in the history taking, but more likely you will get an examination of eye. Sudden patient will complain, sudden painless vision loss. Here is unilateral, but patient will have the pain, okay? But here in the central retinal and the vein occlusion, patient will not have pain. It will be painless. And the fundoscopy will reveal like pale retina and cherry red spot for CRA, what means central retinal artery occlusion. For the vein, it will be like something we say the pizza thrown on the wall, like this will be on the fundoscopy. What is the management for the CRA, guys?
CRAO is a real emergency. We have to admit the patient to the research. We have to involve the ophthalmologist on board. Then at the same time, we have to offer the digital global massage along with, we have to go for the arrangement for the thrombolysis, because it is a real emergency. The patient may have the permanent vision loss.
No, what
and we have to offer the aspirin display.
Your I'm asking ED management, what your step will be? Timolol drops, the acetazolamide, acetazolamide, yeah. This is your job, and then you refer.
Okay.
That's it.
Thank you. Okay. Thank you for clarification, sir. Thank you.
Yeah, you're welcome. How about the central retinal vein occlusion? Just go ahead.
Can I interrupt, sir? Can you just stepwisely, can you just say what we should do first in the central artery occlusion, please?
I think a few things you need to do in the ED, okay? First, you will say, the based on your information, I'm going to admit you under ophthalmologist or eye physician, or you later on, yes. You will say like that. What I'm going to do, I will do the examination of your eye, and also the examination contains three things: the outer eye, inner, and the chamber inside back of your eyes. Also, we can say with fundoscopy. If it's confirmed that it's CRAO, then I will do the ocular massage for you. I will give you the medication called acetazolamide to decrease the pressure of your eye, okay? And I will give you the eye drop to help you. And then your management will be decided further by the ophthalmologist or eye physician, because you already admit under that. What you have to do, or if you are not going to do, you can also give mannitol to decrease the pressure. Clear so far? Three things you need to do in the ED: massage, temolol, and the acetazolamide. Clear?
Yeah, clear. Thank you.
Okay.
Clear, sir.
CRAO, you need to refer.
Yes.
That's it. The next we are going to have is retinal detachment. If you find it in the history, you suspect, you need to do examination with fundoscopy. You found, refer this patient. You cannot do anything, but you need to tell him a few things, like that you require surgery, okay? And if this the surgery is successful for 6 months, you haven't got a problem, that means you lifetime you will not have problem. Just need a few things to aid it. Okay, so this patient also need to be referred. But you always need to make sure that you need to go for the observation room, admission, research room, you need to aid it. And you also need to aid the examination. Examination, 3 parts, the outer or outside of your eye, the back of your eyes, like these things you need to aid it with fundoscopy, or you can say equipment, we call it in the fundoscopy, okay, or ophthalmoscope, what word, any word you use, okay. And then you say, I will refer you, if it's confirmed, you must use this word, if it's confirmed, you never, because you're suspecting, you're not sure. If it's confirmed, I will refer you to there. Okay, so glaucoma, this could be very common in the ED again. So the patient will say, maybe he will say, I was reading a book outside and suddenly I don't know what's wrong with my eye and I cannot see. I feel uncomfortable like this, he will say. And if this patient said like that, think about glaucoma. Okay, so what is the management plan for glaucoma, guys?
Also, to reduce the congestion, we add pilocarpine drops.
Yes, pilocarpine.
Yes, pilocarpine. Good.
Excellent, Tahir.
Excellent, guys. Yeah, this is what you have to manage the glaucoma, okay? So then you have to arrange a follow-up with the ophthalmologist, what we call the eye physician. How about papilledema?
Sir, could you repeat the last one, what you said for the glaucoma management?
Pilocarpine. Pilocarpine.
Pilocarpine. Papilledema, anybody know?
Yes, sir. There is a edema of the optic disc due to the increased intracranial pressure, and the patient presents with photophobia, and so for the treatment of the papilledema, we have to admit the patient into the research, and we have to place the patient in the head up to the 45 degree, raise the head and up to the 45 degree. Then we have to give the mannitol along with the substeroids, sir.
Yeah, mannitol you have to give. That's correct. Steroid, you don't know what is, you don't know what is the cause. Okay.
Yes.
So
yes,
it's always be underlying cause. You don't know what is the cause. Once you find the cause, then you have to go for treatment. But anyway, it's raised intracranial. For that, you have to go for mannitol. Got it? The rest of things all depends on what is the cause, either the carcinoma or it's the stroke or any other reason. So you have to take a step accordingly. If there, and you also need to say, I will go for examination, back of your eyes, the nerves, okay, brain nerves. Then you need to say if there is no any problem, I can, or usually I said the secondary, so you must need to admit this patient or refer this patient to the medical team first. You must, because this patient never come up with any reason. There must be some problem. For example, as I said, the carcinoma, the stroke, hypertension, or anything, what could be. Okay. So these all.
So can we give hypertonic saline instead of mannitol?
When do we give the hypertonic saline, guys?
We have to give the hypertonic saline in case of hypotension.
Yeah.
Hypotension along with the increased IC.
Yes.
If there's renal impairment in
yes. In this case, you need to go for the hypertonic, but you can give, but better to give in when it's required. What does the guideline say? It's required in when the patient hypertensive. Otherwise, you go for mannitol to decrease the pressure. Okay. The TIA, glaucoma TIA, I think so, CRAO, maybe, not sure. These are very common condition if the eye history came up to you. Okay, if the patient came up to visual disturbance. So what about TIA, guys? What is the management for that? In ED, I'm
First of
talking.
all,
I'm talking about ED. Don't go for any other thing. Just talk about ED. Yeah.
We'll give the patient aspirin 300 and we will arrange follow-up with the neurologist within 24 hours and we will order MRI for the patient.
Yeah.
we will do the Rosier score, sir, also.
Nice guideline said when you suspect TIA, you
Sir,
don't.
we will give the aspirin and the.
Yeah, I'm coming up to you guys. Thank you. You guys are doing well. That's true. So what you have to do, you say, according to nice guideline side, you don't need to go for any score or any ABCD. You just know you found suspect. Okay. You need to give a high dose of aspirin, 300 milligram, and then you refer this patient to TIA clinic. Go for the city. What a investigation should be done within 24 hours. This is your job. Okay.
Great, very simple.
Yeah, this is very simple from your ED. You don't need to go for Rosier score. This Rosier score, even you need to go for stroke patient, okay? Or TIA.
Should we get CT head done at ED?
Excuse
CT
me?
brain? Should we go for CT brain in ED or not?
No, the guidelines say you don't have to do, but you can do. If you think the guidelines say if you cannot arrange the appointment with the TIA clinic 24 hours, if it gets longer, then you go for CT. But normally you give just the aspirin 300 milligram, then refer this patient. Okay. This is urgent, but in case you don't give, then 5 days aspirin you can give in case the TIA clinic appointment is delayed. But it's not problem for us because we are not preparing for intermediate. We are in OSCE, so you just verbalize. Okay? So you will not have this complicated scenario. Overall, the nice guideline is this 300 milligram without doing any score ABCD, just refer this patient to TIA clinic, arrange appointment within 24 hours.
So regardless of blood pressure?
You don't have nothing to do with TIA. It's not necessary. It must be thrombotic cause, not the blood pressure at all. Okay?
So if it is multiple episode, we should admit, right?
Where?
In multiple episode of TIA.
Multiple episodes, sir, of TIA.
Multiple episode, there is you need to there is no any such thing I found, but this can be work in DVLA.
Yes,
Anyway,
sir, we have to take advice for DVLA, no?
DVLA,
in the first TIA and the multiple, because it is a part and parcel of TIA management.
Yeah, so what I say, the TIA you found is multiple or single. You give the aspirin, you do your job. This is your job in ED. That refer to TIA clinic, that means the specific treatment will be given by TIA clinic, not by you. They will confirm first with the CT, then they will take the step what they have to do the next one. For us in the management in the ED, we just go for aspirin or any blood thinning medication in case the aspirin contraindicated. Got it, guys? So yes, then you have to refer. The proper management will be given by TIA. Okay, next we are going to have the designated vertigo. This is also very, very common, but in the common is the benign paroxysmal positional vertigo. So sometimes,
Sir,
yeah.
Sorry to bother you, sir. In our screen on the laptop, we are not seeing the top line, and because it is merged with the green line along with the black line, then we are not seeing this main heading of this main topic. Understand?
Really? Oh my gosh. Can you read
No,
the?
we can see.
You can see, right? Everyone who
Yeah,
cannot.
this clear.
This very clear, right? Presentation of vertigo, dizziness by cause. Is that in upstairs?
Ye-
Oh, sorry.
Yes, we can
I got
see.
it.
Yeah.
Thank you, sir. Thank you. It's my problem. Thank you.
Okay,
Sorry to bother you, and
that's
sorry to interrupt all these students.
it's
Thank
okay, no problem. So the presentation of vertigo by or dizziness by cause. So what in examination, I never encounter any station like that, but the people say, some say this is very simple, come up like dizziness, they mention patient came up dizziness, but sometimes they mention in different way the patient has a fall, okay, or maybe patient come up with the collapse. So it depends whatever you're going to have it, but you need to be ready for any kind of situation you're or the case you're going to have. Okay, so vertigo, there are maybe vestibular causes, can be a memory disease, or maybe there are other causes, but we will focus just the important one is the paroxysmal position of vertigo, okay? So there are two types, the autological or the neurological, and the central or the peripheral. So you need to take a history, you will know these all everything, but the paroxysmal, the positional, maybe patients say, I wake up, okay? I wake up, I just want to go to the toilet and I suddenly something wrong with me, I fall down. But if you ask him, did you lose your consciousness? He will say, no, but I found something is moving around me. Like he will say like that. If he said like that, that means it's dizziness. You will follow the approach, this one, adipara. Okay? So what you will say, you found he has vertigo, then you will say the based on, and this is very important, I want to simplify that you get the important point from here, okay? Based on your information, the most likely problem I suspect is paroxysmal positional vertigo, we call this condition in medical term, or just in English also, I think there's the same, but the paroxysmal little bit difficult word. So what I'm going to do, I'm going to keep your observation. Then I will do a test. Which test, guys?
Apples maneuver?
No. Dix-Hallpike maneuver. Yeah. Dix-Hallpike maneuver. But you don't need to say that I will do Dix-Hallpike maneuver, but you'll say, I will do a test. In this test, what I'm going to do, I will let you sit on the couch, okay? I will hold your head and move to one side. Then I will ask you suddenly to go down in supine position. While doing so, I will look at your eyes, okay? So if it's positive, in positive, the patient will have the moving of eye, means patient will have the vertical or rotational nystagmus. Okay, if I found this test is positive, then I will do another procedure called Apley maneuver to treat this condition. What I will do then, I will turn your head to opposite sides, okay? Then I will ask you to turn your body on the shoulder and to down your head towards the floor. Then I will let you, I will ask you to wake up in sitting position. Again, I will turn your head to down, and after that, it will be fine. Your condition will be better. This is the management plan last. So this is Apley maneuver, which I explained second step. For example, after you turn his head to control letter size, then you need to turn his side towards the floor, patient turn to his own shoulder, then let him wake up. So this is the Apley maneuver. So you need to, just what you have to do, you need to simplify these maneuvers both. Get it, guys?
Yes, sir.
This is the management plan. There is a test, and also there is the management plan. Both are done if you suspect proximal. Okay, and then you say I will arrange a follow-up. You can come back 2 to 3 weeks. If condition not improve, I will do again the same procedure. If not successful, I will refer you to ENT. Your management plan done. Okay.
Thank you, sir, for simplifying the things.
Guys, everybody knows the medical term. Patient doesn't know nothing. You need to explain very well. Try to focus on management plan very well. Don't do the silly mistakes. The things you're doing, like I'm going to refer you ENT, so why you are here? Go home. Sorry. I just mean that you will lose your score, so I don't want to let you lose a score. I want to try to let you pass. Don't do this, because I know this station you will have almost same station. These all are repeated, but don't do silly mistake. Okay, so this is about that.
Will the time be enough to explain the whole procedure? The whole maneuver, will the time be enough in the station?
Guys, when you will practice again and again, you will be master. Okay, you will go very fast. I told you the 8 minutes is a lot of time. It's just takes time. You need to practice. 2 times, 3 times, 4 times. Once you're done, you're ready. Means you'll never forget anything. You will quickly, Eplem maneuver, right? You know about it. You know about the Dix-Hallpike maneuver, right? You know this test. You just need to simplify the words how much you can, but try to avoid this medical term all the time. But you can say it's called in medical like this, but you need to tell the procedure. Patient you cannot treat without giving management plan. If you don't tell the patient that what you are going to do and just blindly give treatment, do you think so it does make sense? No. In the UK, if you want to practice in the abroad, in any developed country, even in Australia, US, in the UK, or G7 nations, so they have this important, like I don't say at all we all the time follow everything like that, no, but for the purpose of exam you need to go exactly like this way. And in real time they also ask you special question. It's not like patient doesn't understand and he will just go home and blindly believe he knows. Patient or more smart, they search on internet even before go to doctor sometimes. So need to be very careful. Okay, so it's clear so far, guys?
Yes, sir.
Yes.
Yes, sir.
I don't know if someone is, please do not interrupt. Thank you. Okay, so next is we are going to have the rash. This is also very common station. Okay. So we have meningococcal infection. Hello guys, can you hear me, everyone?
Yes, we can.
Okay, thank you. So these are the symptoms you will get it, okay, from meningococcal infection if the patient do have, especially meningococcal septicemia is a severe condition of the meningococcal meningitis. So could you please tell me what is your step in this patient? Hello?
We will tell the patient that the disease that you seem to have is a form of bacteria which is called Neisseria meningitis, and it can spread very rapidly. So I will need to administer to you antibiotic as soon as possible. The name of the antibiotic is ceftriaxone, which I will give to you through your vein, and later on I will also take you some of the blood tests. I will not wait for the results of the test for the administration of antibiotics, and from there we will proceed ahead.
Okay. So the antibiotics we give in outside of hospital, benzyl penicillin, the entire hospital, after admission, you need to admit this patient, right? Meningococcal septicemia, if patient comes, you need to must admit this patient. You need to start the IV antibiotics, ceftriaxone or the ceftriaxone, okay? We will come up to the management plan for this one. This is just like that, as I explained to you. The next is ITP. So what is the management plan for ITP, guys? What you will find in the test, full blood count with the coagulant factor.
In ITP, there is a marked decrease in the platelet count.
Yes,
that's why
bleeding time increase, platelet count decrease. So there are several causes for that. Okay, so what you have to do, this patient
we have
treatment
to give the
It's
intravenous
an IV
immunoglobulins along with the fresh frozen.
Find the cause. Okay. If immunic cause, you need to IVIG and corticosteroid. That's it. And the other like platelets, you need to check the count. If it's decreasing, you also need to transfuse. Okay.
Yes, sir. Thank you.
So HSP usually the young patient or children. Anyway, you can get it. This is in pediatric, the history taking, or you can adult, and both can possible. So what is the treatment for HSP, guys?
So steroids.
Steroids, sir.
Okay. How much you will give? If the child 1 to 2 mg. Yeah, according to body, 1 to 2 mg per kg per day. Okay. If the maximum 60. And arrange GP follow, okay?
Okay.
And you need to give advice, like usually this condition can go away within 4 weeks. Joint pain can go with the 72 hours. Must aid the paracetamol or the NSAID for the joint pain. You need to verbalize the patient, and also you need, if in severe condition like nephrotic syndrome, a patient has developed, you need to arrange follow-up with the nephrologist, okay? If in severe cases. But usually you will not have this in severe leg ulcers. Okay, so what is the most common cause is venous insufficiency usually. So what is the treatment for the leg ulcers in NICE guideline, guys?
If there is a venous ulcer, we have to treat the underlying cause. That is, we have to treat the varicose veins, for which we have to do the Doppler study. And
you know that this patient should tell you in the history that he has this problem. Even you will know from beginning, I think. The problem is management. Yeah, okay, underlying cause 1. Okay, good. Another. This is going on, this patient must be going on the treatment with that. Is no problem about that. The problem is leg ulcers. How would you manage this ulcer? In the ED, is this your job, what you will do?
In ED, we have to wash the wound with the normal saline, and we have to do the we have to apply the compression stockings.
Yeah, compression therapy. That's good.
Charing Cross compression stocking, that is 35 to 40.
Multi-layer bandage, okay. And there is another hemorrhagic, intrahemorrhagic, we have to aid. This called pentoxylene, I think, oxaphylline. Pentoxylene.
Yes, pentoxyphylline. Yes.
Yeah, you have to aid it. Anti-hemorrhage, okay. And you will advise this patient to elevate your leg around 30 minutes after every 3 to 4 hours, like that. Oh, sorry, 3 to 4 times a day. Okay, very simple and very straightforward. But if patient has swollen, fever, uncomfortable, then you can also add the antibiotic flucloxacillin. I think flucloxacillin. I think it is very, yeah, it's a type of, yeah, flucloxacillin. The penicillin antibiotic, you need to aid it in case the patient you found the patient has local infection. But if the patient is developing severe infection, when you take history, patient say, I have fever, I had a fever, then you will say management plan. If you say, you can say that if I found that you you have severe symptoms, like as you mentioned, a fever, or if your heart rate is high, if I found systemic unwell, you need to admit this patient, okay? This is going on a sepsis. Anyway, you will not have this case, but you should know about it. Okay, this was the leg ulcer, so you can have this one. Another, we have inflammatory bowel disease, and the patient will have abdominal pain, but ulcer, which is pyoderma gangrenosum. So I see one station like that. People told me like they had this station, but I'm not sure. It could be, but I think leg ulcer can come up to you. If not, then this can be possible. Both can be possible. HSP usually in children. So what is the treatment for IBD, guys?
Painkillers or surgery?
This is the no. This is the steroid enemas, sir. Steroid enemas.
Yeah, the malazolane drugs like that, methotrexate, like this kind of drugs we use. But in the ED, what you have to do, you need to give the painkiller and refer to gastroenterologist. Just give supportive treatment. What else required this patient? Okay, just supportive treatment and then refer. Clear? But you will have this as a rash. Maybe they will. I don't know exactly, but if they give you in the rash station, so they are talking about pyoderma gangrenosum. So patient will have this rash. Usually they don't cause any rash outside the body, but it's associated with this one. This is very, very rare. Very rare condition. Not everyone have, but I found some people were too much stressing on it, so can be. Anyway, so this is clear so far, right? This we are done. Yeah, next we are going to have another jaundice. Sorry, here is jaundice. Okay, so the prehepatic, the intrahepatic, we can have the posthepatic. The post, usually patient will present to you, he will say right upper quadrant pain, the infection, acute cholecystitis, cholangitis. We have a pentad, okay, or triad, Charcot triads. So we need to follow that. And the prehepatic can be anemias, can be drugs, co-amoxiclave, sometimes called Gilbert syndrome, which is in a stress condition, patient likely have any systemic disease, and then or when patient is infective, this visible. Okay, so this is from the genetical. Another, we have intrahepatic viral hepatitis, known alcoholic fatty liver disease, autoimmune, etc. So you know about it. It depends on the patient history. If alcoholic, so you need to stop him, ask him to avoid the alcohol consumption, etc., and arrange a follow-up with the alcohol specialist. The viral hepatitis, you need to do some tests. If it's confirmed, then the gastroenterologist, and you need to tell him what management you are going to do. The gallstone, if it is not really bothering, maybe you can discharge him with the printed leaflet. But acute cholecystitis, you must admit and refer to surgeon. Acute cholangitis also must admit and also refer to the relevant specialty, the medical or surgical. Pancreatitis, we already usually come with the pain. Okay, so next is, we have the acute urinary retention. This is likely to come, and it's very common. So when you take a history, maybe you will have history in drug history. Maybe you can find GP. I know a guy, he has this station too. He told me that in the drug history, he found that the patient said he went to GP and then he got this drug. So how it's true, I don't know, but this station likely to come up in the exam, acute urinary retention. So what is the treatment, guys? Hello?
Then we,
Yeah,
if the we have to
catheterization.
treat the cause.
First, what is the most common cause?
Is the
Benign
benign
prostatic
prostatic hyperplasia?
Yes. If the patient has a prostatic enlargement, what you will do? How would you treat?
Catheterize.
Catheterize.
Okay, you did it. Done.
Cecilia.
You are forgetting very important international prostatic score.
IPSS score. Okay.
Yeah. You need to remember it, okay? If greater than 3, you need to add the drugs as well. Okay?
Okay.
And advise what you will say? Carer or the patient, any of one, should be sent to a nurse, okay? Continence nurse. What? Continence nurse to learn about what? Catheterization. Because this patient requires catheterization. If it's a very old man, maybe he needs to do self-catheterization all the time, right? Or yeah. So you need to also at this point, I will refer you, or I will refer your carer to the continence nurse to learn about or to train about the self-catheterization. So this point you must add it, okay? Must.
Okay. Okay.
Got it? The alpha blocker drugs, yeah, tamsulosin. These all drugs you need to remember, and you need to tell them the management is totally almost the same. Just need to add a few points. Number 1, catheterization and other drugs. If required, score screening tool, you must mention IPSS. Must mention that we will do this score, and then we will go for minimums greater than 10. We will give you this drug. We will also let you be, I will also refer you to the continent nurse to learn about the self-catheterization to the patient, or you can say to the carer of the patient, any of them. Okay. Good to go? Good to go?
Yes, sir. Excellent.
For somehow you need to admit this patient. You have to do catheterization to relieve his obstruction, and then you need to give drugs for that time, but eventually you will discharge this patient. Okay?
Okay, sir. So could you please repeat the score required for this
I
acute
think
retention?
8. You can search on, there is a nice guideline, and if you can't find it, I will send you later. Just remind me, guys, just remind me that you need it. I will take a shot for you. Okay? Okay, hematuria. So we are, is done, I think. Yeah, hematuria, again, HSP. The young people or the children, the same treatment as we discussed. Nephritic syndrome. So what is the treatment for the nephritic syndrome, guys?
This is no, this is the antibiotic.
No, this must be the most commonly this SLE or the autoimmune disease or involved GBA posture syndrome,
So
good
steroids.
posture syndrome. These all are involved. So you will give just symptomatic treatment. Usually, patient also have hypertension in this condition, so you need to
Control hypertension.
control hypertension with SE inhibitor. Okay, and the diuretics require this patient to avoid edema. Right, and you need to advise this patient to modify his diet like low sodium diets. Okay, if required, the statin drugs you should be aided. So these all things are involved in nephritic syndrome. So this treatment you give, and then you refer to the nephrologist for further management. But you have to do your job. Clear? SE inhibitor, first mode, diet modification, underlying cause. Treat the underlying cause. Okay, bladder and renal carcinoma, you need to refer this patient to oncologist. Just give symptomatic treatment what the patient is having, then refer. You cannot do anything with that, these two both patients. Okay? So this is about the hematuria. Maybe there are many other conditions as well, but just I focus on this impulse one. Next is we have ankle or limb swelling. Usually come up with the ankle swelling, so the can be limb, but both can be possibly associated. Both the cellulitis for the ED, I think more commonly you can get the cellulitis or the nephrotic syndrome. So what is the treatment for the cellulitis, guys? Sorry, cellulitis.
We will do the ERON classification for cellulitis, and then we'll decide according to that if it's ERON classification 1, then oral antibiotics. If it's classification 3, 4, or 2, then we will give IV antibiotics.
Fantastic. Wow.
Excellent.
Aaron classification. Good. Very good. So you have to go for the Aaron classification. You just verbalize, you don't need to go very deep. But if the patient is systemically unwell, you just admit this patient, okay, and give an IV antibiotic. If the patient, if the patient is the class 1, the class 2, 3, and 4 usually have the comorbid and also the systematically unwell. So 4, 3, and 4 both need admission. 1 and 2, you can discharge this patient. Okay. The first line antibiotic, guys. Yeah.
Flucloxacin, sir.
Yeah, flucloxacin. So this is a treatment. So you guys, you're doing great. So nephrotic syndrome. Again, the underlying cause could be the same treatment like nephrotic, almost nearly same. All the drugs, patient hypertension, ACE inhibitor, the edema, the furosemide, and the other like patient advice like low sodium diet and then refer. Heart and liver failure depends on the condition, what is the cause, and treat the underlying cause and give symptomatic treatment to both in both conditions. Okay, so it's done. I give you, how much time do you want to have a break, guys?
15 minutes.
Okay, so let's come up after 15 minutes, okay? And then we will go for the role play. Sorry, okay. So see you guys in 15 minutes. The webinar will be continue open on. I just need to stop recording and then we come up with the role play. Okay, see you guys in 15 minutes.
Okay.
Okay.
Start.
Can you please give me just 1 second? I need to check something.
Okay.
Just 1 second. Some stations over. Okay.
Should I start?
Yeah.
Okay. Hello, I'm Dr. Rayhan, emergency registrar. Can I know your name and age, please?
Yeah, my name is Nancy. I'm 65.
Nice to meet you, Nancy. Can I know what brought you here today?
Yes, today I woke up and I want to go to my garden, and while I walking, I don't know what happened. I fell down.
Oh, I'm sorry for that. Are you okay now?
Yeah, I'm okay.
Okay. I would like to take some information from you. Will that be okay?
Okay.
Do you want anyone to attend with us?
Yes. Yes, ma'am.
Okay. Who do you want me to call?
No.
I'm sorry.
I want, you said attend with me. My daughter is okay.
Okay. Okay. Can you tell me more about what happened?
Yeah, it is. In the morning, I wake up, I walk to my garden, and suddenly something like I fell down. But then I look up and I feel like something going around on in front of me, just like that. And I had then I feel nausea, like vomit.
Okay. Okay. May I know if by any chance you lost consciousness?
I cannot say I lost my consciousness, but yeah, it's look like surrounding is not very good to me. It's just like just like it's something going round and round around me, like that.
Oh, yeah. Okay. And did it start sudden or gradual?
It's suddenly.
Okay. And do you still feel dizzy now?
No, I feel okay now.
Okay. Did you notice anything that makes it worse or better?
I don't know.
Okay. May I know if this is the first time this happens?
It's happened before too, but this is just like this is first time. Yeah, it's not like this before. No, it's first time, I think.
Okay. You mentioned you feel nauseous and you vomited. Am I correct?
No, I didn't vomit.
Okay, only nauseous. Okay. Any other symptoms? Any tummy pain?
No.
Any hard breathing?
No.
Difficulty breathing?
No.
Okay. Any chest pain?
No.
Okay. Any numbness in your limbs
No.
or any weakness?
No.
Okay. Any headache?
No, but just like I feel ringing in my one of ear. What's that?
Oh, okay. And do you feel also that your ear fullness in your ear?
Kind of.
Okay. Any ear pain?
No.
Okay. And any fever? Are you not running any temperature?
No.
Okay. Can you tell me more about your past medical history? Do you have any chronic health disease or problem?
No, I just have some problem. Sometime I'm anxious, or sometime I have very low mood like this. No, other than that.
Oh, okay. Are you on any medication?
Yeah, yesterday my GP gave me some medication for my depression. I also take medication for diabetes, hypertension. Yeah, I take some medication every day for that.
Okay, okay. And are you allergic to anything?
No.
Any previous surgery?
No.
Okay. Um, can you tell me more about your social life? Do you smoke or drink?
No.
Okay. I just you came with your daughter. May I know where you stay? If you stay with her or alone?
I stay with my daughter at home.
Okay. Okay. Um, I want to know what if you have any idea about what causing your symptoms.
I have no clue.
Hello?
I have no clue.
Okay. And can you tell me what concerns you the most?
I don't know, doctor. I took this medication. I feel like something wrong to me today.
Okay. Yes, I appreciate your feelings. I would like to tell you what I want to do today. I want to take your observations and examine you properly, examine your chest, your heart, and I want to take a look at your ears with a special device. I'm suspecting that what you had today may be due to an ear problem, maybe an infection. So I also want to run some tests like full blood counts. I want to check your inflammatory markers. And also I want to do tracing for your heart. Are you following me?
Okay.
Okay. And how do you feel about this? Is this sounds okay for you?
Okay.
Okay. And do you have any other concerns apart from this?
So, doctor, I will be here or I will go home?
No, it's simple. It's simple infection. We'll give you some medications for it to ease up the dizziness, and you can go home.
Okay. Thank you.
Thank you.
Guys, what do you think was the problem?
She didn't ask about the medications that it may cause this problem. You may take aspirin or something like that.
I take
and
medication
maybe
anti-depression. Is the cause of my this vertigo. Okay.
Yes.
Got it, guys. So the approach, I don't know what's her name. What's your name, please?
Ryan.
Ryan. Could
Ryan.
you, Ryan? Okay. Okay. Could you please tell me? Did you took the ODPAR nicely? Did you ask me? Do you have any other symptom associated with it or any other problem? Did you ask me?
I'm not sure because I was a little bit nervous.
It's okay, no problem. Okay, so the problem is that first of all, you didn't follow very well the approach. Okay, last time I told you that you don't need to move the patient suddenly to resus. It's not necessary, but if you think so, it's okay. I give you the clue that I fell down and I found the things are surrounding or not okay, just like moving around me. So it's give you a clue that it's vertigo. And we discussed the vertigo previously. I think I mentioned the drugs also what the cause the vertigo. And I gave you idea about the medication yesterday GP prescribed me since I don't feel well. That means the cause of my condition is the medication. So you can simply say, based on your information, the most likely problem you're having due to your medication, probably, and your this medical problem, this problem called in medical term vertigo. Okay, so you can add. It could be other different causes. I need to rule out. Okay, And then you say, so what I'm going to do, I want to keep your observation room, check your vitals, do examination, and do some tests. You can do the test like head, one is the head test, or if you suspect Dix-Hallback test, you can just mention, don't need to do exactly, just say some test. And then I will check your medication, what is caused. So I need to decrease the dose. Either I will request you, or either I will refer you back to GP with a later that to look at this medication or to decrease the dose, whatever, just like that. But you didn't reach the medication. This is antipsychotic, amitriptyline, antidepressant. These drugs are the cause. Hello, can you hear me? Is it Christopher?
Yeah, I can hear you.
So
I also didn't ask about the duration. And, yeah.
So guys, it doesn't mean it. You see this woman come up with the nausea, and she's 65 years old. She must be on a lot of medication, right? And I give you history of past medical history. I told you many. So when you sometimes make sure that when you see the patient is older and different medications, so most likely the cause of this patient, any condition, would be the medication. Okay, just need to do to rule out other causes and decrease the dose of medication, or I need to review your medication. Do you have the paper? I will see your medication, and accordingly I will change your medication, or I will refer back to GP with the referral to change medication or do input or something change. It's what you can say simply, because this is relevant to medication. When you stop medication, automatically the patient will be fine. This tinnitus, as I said, ringing my ear, this is tinnitus. There is no any problem. I don't have ear pain. I don't have nothing to, just vertigo and tinnitus in my ear. So it's peripheral, and this is caused due to the medication and antidepressant. So far clear?
Yes.
Yeah.
Yes, sir.
Okay, and the approach really, you're sorry, I don't have a pen. I need to note what you haven't asked, but there are many things you didn't ask. So please be careful to follow approach Adipara, then relevant system. Okay, relevant system. Here is nausea mentioned. Okay, so you need to start with, do you have any other problem like vomiting, diarrhea, to rule out? It also help you rule out, and also to the complaint. Okay, let's so who want to practice next station, please? Anyone? Who wants to practice next station, guys? No worries, I'm here to help you.
Today is my first class. I didn't know the Odipara and all the things you have taught in the previous class. So it will be difficult for me to go along the your teachings.
The previous candidates. Anyone?
Yes, sir.
Any guys who joined my previous try? Can you try, please? You should try it in the live, that you should get away from your fears. Hello? Anyone?
Yes. I will be.
Wow, Zishan. Last time you tried two station. I hope you will try this time too. Let's go.
Okay. My name is Dr. Zishan, and I'm emergency registrar. May I know your name and age, please?
Yeah, I'm Amanda. I'm 27-year-old.
Okay, Amanda. May I know what brings you here?
Yes, doctor. I don't know. Something like wrong with my heart. It's like beating fast.
Oh, sorry to hear about it. I hope you are feeling comfortable now.
I'm okay.
Do you have any chest pain?
No.
Okay. So if you need any painkiller, so that I can help you, and then we can proceed with the further question.
Okay.
Okay. So would you like to explain more about your presentation, your complaint?
Yes, doctor, it started 2 days, I think ago, and I feel like my heart is going out of my chest. I would say it's very fast, and I'm worried about it. I'm worrying my heart a lot.
Okay. So do you have any loss of consciousness?
No.
Okay. Do you have any sweating?
No.
Okay. This as it happened suddenly in the last 2 days. So does it is it happening all the time or any specific time?
Yes, it's nowadays all time. Yeah.
Right. How does it improve in the last 2 days?
It's constant, doctor. It's not improving anyway.
Right. Does anything make it worse?
No clue.
Right. Okay. So if you don't mind, can I ask you some personal questions? Do you smoke?
No.
Do you take any illicit drugs?
No.
Are you on any medication?
No.
Do you have any comorbidities like diabetes, hypertension?
They shouldn't go for systemic review.
Okay. So do you have any shortness of breath?
No.
Okay. Do you have any abdominal pain?
No.
No. Okay. Do you have any dizziness?
No.
Okay. This one. May I ask the nurse to do the ECG, please, for this patient?
Go for miscellaneous, guys.
Okay. Do you this one? Do you have any joint pain?
No.
Okay. Do you have any urogenital problems?
You should go for. Do you have any loss of weight? Yes. Have temperature? I feel hot.
Okay, this is the miscellaneous, right? Okay. So do you have? So may I summarize that you are having the running heart and the heart is racing with the short onset, with the heat intolerance and the loss of weight. So with all these with all these questions, I come to the conclusion that you have most likely endocrine problems, some thyroid problem, maybe most likely. So I would like to investigate you for thyroid function test, CBC, and then I would like to do the ECG for you, and then on these basis, I would refer you to the GP clinic for your management. So do you have any concern? Do you have any question to me?
No.
Okay, I hope it's not so serious condition which which is lethal to you, but it needs treatment. So I will give you the letter to the GP so that they can proceed with your management. So I hope you are convinced with my with my diagnosis and with my plan.
Okay, thank you, Zisha.
Thank you. Thank you.
Okay, good try. So I want to come back to the how to take history first. You ask introduction. Hello, my name is Dr. B. Hindi. I'm ED registrar. May I confirm your name and age, please? Or may I confirm your name and date of birth, please? Yeah, I am Amanda. I am 27. Nice to meet you, Amanda. What have brought you today to the hospital? Okay. Look at patient eye. Okay. Good. I'm sorry to hear this, Miss Amanda. You went this way. Could you please tell me a little more about your heart racing? Okay. Is it continuous or an on and off? Is okay. Did you have similar episode before? Is there anything make it better? Anything make it worse? How would you rate from 1 to 10? Okay, that's right. Then you come to SSS. Do you have any other symptom with it? Okay, no? Okay, then you come up the heart, okay? Do you have any short breath, dizziness, anything? No, the respiratory, then miscellaneous. Do you have any temperature and ice rates? Or do you ever feel hot? Yeah, I feel hot like this. Have you recent any loss of weight? Yeah, loss of weight. Then this is where you go for systemic weight. Okay, and then you come up with the GI because she has nausea. You need to ask her, maybe she has diarrhea because thyrotoxicosis. And then you need to go for the ice. Okay, ice, what do you expect from me? Okay, this kind of thing. Or what's your concern? And then anything you want I do for you to make you better, like this. And then you go for past medical history, surgical history. Then you go for the personal social history, or you go for traveling history. Then you go for further to the management plan. Ask to end of the conversation, like, do you have any question? You want to add something? These all things, then you go for management plan. Based on your information, the most likely problem is this. I want to rule, but I need to rule out other causes. Or you can say, however, I need to rule out other causes. I'm going to keep you in observation or research room or admission. I will do blah, blah. Check your vitals, do examination. Examination will include look, feel, listen. In thyrotoxicosis, you have to do at least listen. I will listen your heart sounds, okay? These things you will do. And then you come up to the investigation. I will do full blood count, which include thyroid, and also some tests, which include full blood count, thyroid function test, the scan of your gland called thyroid in front of your neck. If it's confirmed what I suspect, then I will do this step like this way. It's a sequence, which introduction, open question, then Robert, then the empathy, then the elaboration of the question which you ask open, like, can you please tell me more? Then you go for the again, you need to empathy. I'm sorry to hear that, you say. Summarize should be in the end before management plan. I forget to say that. So this is how you can do. If you cannot memorize, no problem. You just write down. I make one video with Colin, a guy from United States. Why I pick up the native speaker? Because I want you should know how to communicate with the native speaker. Means the actor, which you will have London died, he or she should be native speaker. Most of them can be non-native. Most of them will be native speaker, and they are very fluent at English. And the same like this guy, because he's very clear in the sound. Anyway, so that's why I make this conversation for you, that you should know this type. Pick up this question from that video, this audio actually, a video, but you can pick up from there. and write down on the paper the doctor's note, the patient notes. So then separate what are your notes or the doctor. Then you just follow it, practice and practice. Management plan, I will correct you. Okay. Zishan?
Yes, sir. That's wonderful, sir. You explained very well.
Guys,
thank you.
guys, you need to be ready because it's OSCE. Before we think like that, it's just like you go for exam. Maybe, you know, before pattern was like the RCAM curriculum was like you must pass the 2 recess. The rest of the station wasn't. They give too much importance and the candidates were very low. Now candidates are too many. Everyone wants to do MRCAM and they are checking competency. So if you fail first, I hope no one will be failed, but if you go this way, likely to be failed. If you fail, you will lose your fee, the money you pay, the air ticket. If you're going away from India, if you're not from India, away from India, you lost your money, traveling expenses, your expectation, your time, everything, you lost it. So don't, this history is not a big deal. One time you write down the notes, you just practice again and again, revise by yourself, you are done. Management plan I give you, I verbalize in the video many times. I add some even these slides, how you can tackle down, like classification, how to know what step you need to do, when to give antibiotic, always, everything I explained very well. I think not even better than you cannot find anywhere. So you just need to write down even my words and then important point, and then you can explain in your own words. Just need a little, you need to be little active. Okay. Okay, so who wants to practice next station, guys? Or if someone wants to practice this station, is still there?
Can I go with the next one?
Okay.
Yes, I can start. Hello, I'm Dr.
Okay.
Mariam, and I am the ED registrar. Can I please confirm your name and age?
Yeah, I'm Ru. I'm 22 years old.
Oh, nice to meet you. So what has brought you to the ED today?
Yeah, doctor, I feel just like my breath is stuck, or I would say, yeah, I cannot breathe very well.
I'm really sorry for that. Can you please explain a little bit more that do you have some other symptoms with it?
Around 5 days ago, I had got some problem like a cough, and then it's go a little better, and then again, no, I don't know what's wrong. I feel like something wrong with my breathing.
Did it start suddenly or gradually?
I think it's just from today, so yeah, it's suddenly, I guess.
Suddenly, okay. And it started exactly how long back?
Pardon?
How long back did it started exactly? When did it start?
It's just a few hours ago. I was sitting and I don't feel comfortable. I feel like something goes wrong.
Can you please score your condition from 1 to 10? How bad is it?
I think 5.
Okay. And is it getting worse or better with time?
No, I'm okay. Sometimes when I walk, I feel, yes, not really, but I feel sometimes. It's before I had, as I said, I had the cough, and then it's developed. It suddenly today, just when I walk, a few hours back, I walk and I feel more terrible.
It means it is getting worse with walking.
I guess so.
And is there anything else that is making it worse?
No, no idea. No, any other than.
So can you tell me anything that makes it better?
No, I do have the shorter breath when even I'm sick, but not too much. No idea, no clue.
Okay, have you taken any medicines for this condition yourself or not?
I just take paracetamol because I feel hot.
Because you were feeling hot. All right. And you have had cough, as you told me.
Yeah.
And it's just been a day.
Yeah.
And what do you think it is? What do you think you have?
Maybe I catch a cold.
Okay. And what are you have any specific concern?
No.
Okay, and what are your expectations?
I want to be fine.
Okay, can you please tell me a bit more? Like, do you have any? Are you feeling sick in the gut? Do you feel nausea or like you want to throw up?
No.
Do you have any tummy pain?
No.
Have you noticed any discoloration of your skin or yellowing of your skin?
No.
Any change in your bowel movements?
No.
Any problem with urination? Any change in color or you have to go to the washroom more than normal?
No.
Okay. Have you seen any rash on your body or any skin changes in these past 2 days?
No.
Okay. Have you experienced temperature at the night time? Fever at night time?
No, when I have fever, it's no problem. Anytime can I have fever. Yeah, I had today, and I took
Okay.
paracetamol.
And how did you document it? Was it high grade fever or low grade?
My girlfriend check is was around 38.
Okay. And are you experiencing shortness of breath too?
Yeah, doctor, I said you short of breath.
Do you have any sputum production when you cough?
Yes.
And can you explain to me the color of the sputum?
It's yellow.
It's yellow. Does it have any blood in it?
No.
Okay. Do you have any headache or any vision problem? Have you experienced that lately?
No, doctor, I just feel hot, and that's it.
Okay. Now let me summarize. That you've told me that you have been experiencing shortness of breath, and before that you had cough for a day, and you also have fever, and you have sputum production with it, which is yellow. Am I right?
Yeah, that's correct.
All right. So basically, what I have gathered from our discussion is that maybe you have got a condition called pneumonia. It is basically infection. It is infection of your respiratory tract, the tract through which we breathe. So for that, I will have to conduct a few tests. First of all, I would take an X-ray, that is the film of your chest. I would like to take that film, and I will give a scoring system that we call FORT 65. And in that score, that scoring system will tell me the severity of the condition that you have. And for this condition, basically the treatment are antibiotics. And I will be prescribing you antibiotics. Most probably, I will be giving you amoxicillin. That's the name of the antibiotic, but it will and whether I will give you the antibiotic for via vein or orally, it will depend on the curve scoring system that I've just told you about. And do you have any further queries about this situation?
No.
All right. And any questions you can ask?
No, thank you.
I think that's it.
Okay, the elaboration of the complaint, I told you that I have shorter breath. You need to start with the respiratory, then you ask about the associated symptoms. Do you have any other symptoms like cough? Because you need to, I said I had a cough, or if I already said cough, you can say, doctor, you said after Odipora, you said that you had a shorter breath and cough a few days ago. Do you have any other symptoms along with that? Or you can say, you said that you have shorter breath and cough few days ago, and you also feel hot. Is there any other thing? Then you come up to the next system would be what? What would be the next? You can
abdominal.
You get
Cardiovascular.
cardiovascular, right? Cardiovascular, you go, then you go for miscellaneous, right? Any loss of any nitrate temperature. Then you go for what else? GI, you go for you even didn't go for the nervous system. You should then GI, then the urinary, then genital if you want to edit. If no problem, then you should go for the nervous system. This is where you can go. And another, you didn't tell me where you want to. You want to keep me in observation room or you want to keep me in research room? Where you want to keep me?
Observation.
Short of breath, you need to keep me in, better to keep in the research room to attach to the oxygen. You also need to verbalize. Okay. And then you go for the chest x-ray, etc. and this plane. Okay, no problem. So I think this station was very simple, just you didn't go the concise way. Anyway, no problem, good try, better than before. Okay. So who wants, yeah?
So may I ask that in the shortness of breath, should we suspect, although this is not the case, but should we suspect PE also? Apart from pneumonia.
Yes, I made a mistake. She should rule out the other. She must verbalize that I need to rule out other causes, for example, pulmonary embolism, etc. And also need to say that I will do investigation if it's confirmed. What diagnosis you guys make is a suspicion. So you must tell if it's confirmed. Okay, you must. Just like fingertip, you know about this. Don't show the examiner that you are confirmed, okay? If confirmed, I will do. Yeah, you need to rule out differential, guys. Yes, you must. Okay, so anyone want to practice?
Sir, for ruling out the diagnosis, will we have to, do we have to give the management plan
No. Just rule out, just verbalize that the doctor should, the examiner should understand that you know what are the differential. Clear?
And I think in this question relevancy, she should ask about the cough pain also and the Wells score.
Yeah, no. The Wells score is not necessary because cough is sputum, and with the yellow sputum, there is a hemoptysis in the pulmonary, and usually the pulmonary embolism totally different, no fever even. Okay, so pulmonary embolism with the pneumonia is totally different. Just you need to keep in all the differential. Excuse me, could you please mute your mic? Okay, clear? Zishan, clear?
Yes, sir. Yes, sir. Thank you.
Yeah, because no fever. Okay, no fever, and the pulmonary embolism is the sputum is hemoptysis, not the yellow. So it's clearly it shows indicate this is the pneumonia. But you can keep the differential like asthma, like the COPD, okay, bronchitis. This all you can keep in differential. Next, anyone want to practice?
Yes. If somebody is not, then I can.
Okay. Any other than Zishan? Anyone want to practice?
I can do someone
Yeah,
else doesn't want to.
I will do.
Okay, Naz, the Dr. Naz, I think. Okay.
Yeah.
Okay. This is station for you.
Okay.
Okay.
Yeah. Okay. So hello, my name is Dr. Naz, and I'm an ED registrar. So could you please confirm your name and age, once?
I'm Simon. I'm 20 years old.
Okay, Simon. Nice to meet you. What brings you to the ED today?
Yeah, doctor, I had developed this rash. Malone.
Okay, and I'm sorry to hear that. And since when have you noticed this rash?
It's today.
It's today. And where is the rash exactly?
On my leg here, on my right side.
On the right side of the leg, is it? Just one limb?
No, another also, but not really much.
Okay, so you have noticed it today. Do you feel that the rash is increasing, or is it still the same since the time you noticed?
Is the same?
It's the same. And since how long has it been there? You said today, but can you be more specific and tell me from how many hours have you noticed it?
A few hours.
Few hours, okay. And do you feel, is there anything that have made it better or worse since the time you've noticed?
No clue.
Okay. Is there any pain associated with the rash, pain in the limbs, or pain while walking?
No.
Okay. Is there any itching in the where the rash is or anywhere else in the body?
No.
Okay. Do you feel feverish as well, or have you recorded any temperature?
No, doctor, I had a fever.
You okay? And since when have you been having this fever?
Before I had around 6 days before. I had a fever. It was my mother checked it. It was 38.5.
Okay, so this was 6 days back. You had fever. So right now, do you still feel feverish, or you have fever?
Yeah, I had it. I took paracetamol.
Okay, you've taken paracetamol. So has it been continuous, the fever, over past 6 days, or has it been intermittent?
No, take paracetamol, feel better.
Okay. Any other things, any other medication that you've taken apart from paracetamol?
I went to GP with my mother. He gave me medication, but it doesn't work, I think.
Okay. Do you remember what medication GP has prescribed?
I don't know. My mother knew.
Okay, fine. And tell me about any other symptoms that started when you had fever, apart from this rash.
I had a headache.
You had a headache. Okay. Okay,
and I also feel like nausea sometimes, yeah.
Okay. Has the headache and nausea been persistent since 6 days?
On and off. I take medication, I feel okay, then since again.
Okay. Any other symptoms that you've had?
Doctor, I don't have any energy.
Any cough, any vomiting sensation?
Yeah, vomiting.
Vomiting sensation is there. Did you vomit, or do you just have the sensation that you might throw up?
Said nausea, doctor.
Yeah, just nausea. Okay. And what about headache? How bad is it? Has it been continuous? Can you please tell me, has it, like, when have you been getting headache? Like you said, it started 6 days back, right? So can you elaborate a little bit about it?
Yeah, it's headache is on a head and sometimes on my neck also.
Pardon me, could you please repeat?
Yeah, headache and goes to my neck, and also I have some pain in my neck. Sometimes I cannot sit well.
Okay. And this has been continuous since 6 days?
Yeah, on and off. I take medication, I feel better, and then again the same.
Okay. Okay. Is there any like giddiness or any dizziness you feel along with the headache?
No.
Okay. And is the headache, is it, can you explain where in the head? Like, is it, which area of the head do you feel the pain is more? Is it in the front, back, or just, could you specify it more?
Doctor, move on to next system.
Okay. So, any other history, any urinary complaints you have?
No.
Okay. And fine. Do you have any other, like, past history, any medical or surgical history in the past?
No.
Okay. Any other medications that you've taken apart from the ones prescribed by your GP?
No.
Okay. And what do you think? Do you think it may be any triggering factor what has caused your symptoms?
I don't know. I have no clue.
Okay, is there anything you're particularly worried about because of this?
I'm going to die. Am I going to die?
Okay, fine. Okay, don't worry, we'll take care of it. We'll investigate as to why this is happening. Okay, and tell me more about your personal history. Do not mind. I would have to ask certain questions like, do you smoke?
No.
Okay, and use of any other recreational drugs?
No.
Okay, so from what I understood, from what you told is that you had episode of fever, which like you have fever, it started 6 days back, along with the headache and nausea, and which has been there on and off, and you have been taking certain medications prescribed by your GP. And since today, you have noticed bilateral like rashes on both your limbs. Is that right?
Also headache, nausea.
Yeah. Yes. Headache and nausea since like past
Yeah.
6 days. Yeah. So, in that case, probably it could be an infection, and this rash can be because of two reasons. Either it can be a bacterial infection which you have acquired, which is causing this headache and this feeling of nausea and vomiting, and which can cause this kind of rash. Or secondly, it can be because of the medications or antibiotics which you're not able to specify. That can be the thing which has caused this rash. Okay, but in any case, I would want to examine you completely and take your vitals and give you an analgesic for your headache and fever, bring down your temperature, and run some blood tests to confirm the cause of this fever.
Okay.
Okay, is there any other thing you would want to know? Any queries you have?
No.
Yeah, that's it. I don't know.
What do you think, guys? What's the problem with me?
It seems like meningococcal.
Like rigidity,
Neck rigidity, and she have to explain the Kernig sign and Badowski sign.
Yes. You guys you cut right. The approach is not very good. It's totally messed up different ways. So the approach, you know why I want to do the meningococcal septicemia very well. First, the rash, and you need to take history very well to, we have miscellaneous. Here you can find me temperature. And we have the, if I say nausea, and you see it's a young patient, you see 20 years old. This could be if the patient come to you, the rash in the lung, and you find, if I told you that I had a few days ago temperature, or if I explained to you, you need to elaborate more. In headache, you should ask this old question to bring up the nervous system first, relevant system first, and the relevant system first, and then go for miscellaneous. In miscellaneous, you can go ask, do you have any temperature? I can tell you yes. Problem is that you messed up everything, so I changed everything and told you by myself I am having this. So this approach is not good. The history taking means you need to gather the information. You need to gather the information. You need to follow the approach nicely. And once you cut it, first of all, the meningococcal septicemia is very, very severe. Okay, it's very hard even patient to talk, but I just make it because there is no any other station where you can practice. We do have the HSP. Usually people practice like HSP, but everyone knows HSP is very, very simple and straightforward. Patient give you sore throat and you can go for. I just make it this young patient is the meningococcal septicemia for you to get use of it. It's likely to come up. But the scenario can be like brought, here I say present to the ED, but he should be the brought to the A and E by mother someone anyway. But the approach of history, please focus on that. Go for the introduction, first open question, how can I help you? Then you go for the empathy, then can you please tell me more about it? Just make simple. If you don't know how to just say, can you please tell me a little more about it? Then I can the patient can tell you a little more, then go for OD-para. After OD-para, if you suspect, for example, rash, come up to the relevant system first, okay? In some history you can get from Winnie, say, can you tell me, please tell me more? In this case, patient maybe say, I had a sore throat before. I had the fever
তাহলে আমি
before.
সামনের চুলগুলো আর লম্বা করতে পারবো না, যেভাবে টানো সামনের চুল পাতলা হয়ে যাচ্ছে।
Okay, good. I don't know, someone, please mute your mouth. Thank you. Okay, so what I want to say that you need to go for system-wise. After system, you need to go for eyes. Then you go for past medical history, the social history, the old history you took it. Then you need to summarize before management. Summarize, then you close consultation question. Like, do you want? Could you please tell me? Do you have any question like that? Do you have any question? If patient don't have, means you close the consultation here. Then you talk, go for management plan. So you divide in introduction, first open question, elaboration of the open question, okay? Empathy, elaboration, again empathy, then go for OD-para, then go for systemic review, then go for eyes, then go for the past medical history, include surgical, then go for social history, then go for if relevant travel, then go for the summarize, then go for the close consultation. After close consultation, go for management plan. These are the few steps. You just write it down, then follow it 2-3 times practice, you will be all right. Okay, anyone? Next.
Okay.
Next candidate. Excuse me, any next candidate? We don't have, we have almost a lot of students
Yes,
are online.
Yes, sir.
Okay, that's great. Here we go. This one.
Yes, hello, I'm Dr. Tasneem, ED registrar. May I know your name and age, please?
Yeah, I'm Robin. I'm 53-year-old. Miss Robin.
Okay, nice to meet you. How can I help you today?
Doctor, I don't know. I found something wrong with my feet and ankle. I see it's just like, it's very soft. And I feel like it's swelling here.
I'm really sorry to hear that. Can you tell me more about this swelling in your feet?
Yeah, doctor, it started around 3 days ago, and but I do have a problem with my sorry. Yeah, I have other. Yeah, I take some medication for my diabetes, and it's okay. It's always okay. But I just wake up last night and I saw there's just something wrong with my feet. First, I found it will be going away. Maybe there is numbness, and then I found that there is like swelling.
Yes, sorry to hear that. It's a swelling in your on both of your feet or just one feet?
It's on both.
And both. Okay, it is started gradually or just suddenly?
I think it's just last night. I wake up this morning and I saw that so suddenly.
Yeah, this started before 3 days, you told me.
Yeah, but I saw this in the last night. Sorry, in the morning when I woke up.
Yeah, you saw it today. Okay. This swelling just is going up to your leg or just in your ankle?
I think this is here in my ankle still.
Yes. Anything make it better?
No idea, doctor.
Okay. Anything make it worse?
Oh, no. No clue.
Okay. You feel any weakness or numbness in your body?
No.
Any history of recent trauma?
No.
Okay. Can you tell me more? If you have you told me you have medical condition diabetes, yeah? You take your medication for the diabetes. Can you tell me the name of medication?
No, it's a Ketrol and the metformin.
Okay. You are with regular follow-up with your GP?
No, I thought I'll go with GP. No.
Okay. You have any shortness of breath?
No.
You have any cough?
No.
You have any chest pain?
No.
Okay. You have any heart racing?
No.
Okay. Did you have any headache?
No.
Any abnormal movement in your body, shaking or something like this?
No.
Any vision problem?
No.
Did you lose your consciousness?
No.
Okay. You have any change in your urine?
Yeah.
Can you tell me more? There's any blood in your urine?
I feel something wrong with my urine. The color has changed. A little bit
Is
like,
it dark in color?
yeah. Just right. Dorek.
Okay. You have any urethral discharge?
No.
Okay. There's any increase in frequency of urination during the day or during the night?
No, not really. I feel something wrong with my urine, that's true.
Yes. Did you feel you can empty all your bladder in one time, or you cannot empty?
No, it's okay. I can go to the toilet now, normally.
Okay. You have any fever?
No, I don't have fever. Before I had some problem, yeah, fever.
Okay.
But now I don't have.
When you have fever?
Now I don't have. Before I had, yeah.
Mm-hmm. Okay. You have any abdominal pain? Tummy pain?
I had no tummy pain, but I feel a little bit uncomfort inside in my lower abdomen, belly's tummy here, down, but no tummy pain. Just discomfort. Yeah.
Yeah, no tummy discomfort. Okay. This pain is going anywhere or just staying on one side?
Stay there.
What?
Stay there.
This stay there. Okay. Did you feel any bowel change the last?
No.
Okay. Did you feel? Did you have any rash or skin changes?
No.
Okay, you told me you had fever, but now you didn't have any fever. Okay. I want just want to make some sum up for you. You told me you have leg swelling, okay, and you noticed this morning, and you have dark urine, okay, and you have just a little discomfort in your lower tummy. Yes.
Yeah.
Yes.
Yeah, that's correct.
Yeah, that's correct. You want to add anything?
No.
Okay, I want to ask you more question. You have any allergy for any medication?
No.
You have any family medical problem running in your family?
No.
Okay, you smoke?
No.
You drinking alcohol?
Sometimes.
Yes. Okay. You have any history for traveling abroad recently?
No.
Okay. Um, do you have any question for me?
No.
Okay. Based on your information and according to the data that I collected from you, okay, most probably you have a kidney problem. Okay. I will take you to observation room and I will do complete examination for your legs and for your tummy and for your body, okay? And I will run some tests for you, including full blood count, urea electrolyte, kidney functions, okay? And I will do some scanning for your stomach, some scanning for your tummy, okay? And I will do also a urine test to see whether the problem because it is changing in color. Okay. And maybe there is some infection in your urine pathway. Okay. So after confirmation, I will give you some medication. Okay.
Okay.
And maybe you need to go to a nephrologist also. Okay, is that okay with you?
Okay.
Okay. Any question?
No. Thank you.
Thank you. Thank you.
Okay, good try. So, guys, what is the diagnosis, your suspicion?
CKD?
You know, I think sometimes, okay, this might be when I'm talking about the presentation, like I talk about rash, you saw that there was meningococcus septicemia, HSP. So these all cases come from which we already discussed. So if you remember in ankle swelling, what was the cases? Do you remember?
It's a leg ulcer.
Actually, swelling maybe it is the heart problem or renal problem. Okay.
Yeah, the condition was nephrotic syndrome, right? It's likely the condition is this. The diabetes can lead to nephrotic syndrome. One is that. Another problem can be autoimmune, can be many, but the ankle swelling, in this case, which we have in her history, if she goes straight forward to follow all the systems to make the urine system the first one, so might be she can get into this nephrotic. So she just should say, like, based on your information, the most likely problem is it inflammation or infection, guys? Nephrotic.
Inflammation.
Inflammation. The most likely problem there is an inflammation in your kidney. Okay, there are several causes of this condition. Can be autoimmune, can be autoimmune, how to say, means your own body healthy cell attack on your normal cell. Can be that problem. Can be another causes, like can be diabetes. You need to explain it. So I need to rule out the causes. So what I'm going to keep you in observation room, do the examination of your tummy, as you said, you have a discomfort, I will need to check out. Then I will go for some tests, which include the blood test, the scan of your kidney. Okay, this way you need to go. And then you say if it's confirmed that I will give you, but remember that you need to check her vitals. She should have hypertension as well. Okay, I will give you the medication like as inhibitor, the diuretics, to decrease the load, the fluid load in your body, like the swelling will go with this medication. For for your high blood pressure, I will give you the ACE inhibitor you need to mention. And then if it is immune cause, I will give you immune suppressant drugs, which stop this reaction in your body. Okay. I will also arrange a follow-up with the nephrologist. This is how you can simply explain to her. Clear so far?
Okay, doctor.
Yeah, so please try to follow. We already discussed this situation. Why I made these all situation, these table for you guys, that you understand. You get the important points from there. Ankle swelling, what condition I put it? 1, 2, 3, 4 condition maybe. So you must think about it. So might be this one, might be this one. Just go over, and you will go easily. No worries. It's maybe your second time. Slowly, if you practice with your friend, you will get use of this. Okay, so ankle swelling, we gone with the nephrotic, but it can be in several different conditions. Just follow your approach nicely, normally, and the management plan should be in simplified word. Believe me, you will get, if the score is 10, you will get at least 9. Why I say not a 10 out of 10? Because it's impossible you get 10 out of 10, okay? Okay, possible to get 9. This is possible to get 9, but 10, extraordinary. Not everyone can get it, but I cannot say it's totally like you cannot do it, but for sure, 9 out of 9 you can get it, but 10 I cannot guarantee. Let's go. Who wants to practice?
Me.
Okay, good. This is station for you. Guys, can you hear the ringing? After 60 seconds, do you hear the ringing?
No.
No, cannot hear.
I ate the ringing, I ate the time clock. I don't know, something technical problem, maybe not working. Anyway, it's okay. Next time I will be careful. Okay.
Okay. Shall I start it?
Yeah.
Okay. So hello, I'm Dr. Medina. I'm a registrar. May I know your name and age, please?
Yeah, I'm Ryan. I'm 68.
Oh, nice to meet you, Ryan. How can I help you today?
Yeah, doctor, I feel like some swelling in my tummy here. I don't know what's wrong, and I tried to go to toilet, but nothing came out.
Okay, sorry for hearing that. Okay. Can you tell me more about what happened?
Yeah, it's excuse me. Please mute your mic. Thank you. Yeah, it's doctor. I don't know. Before I had the same problem, but I mean a little bit like, but it's worse now. Before at least I can go toilet sometimes, but now it's like I don't know what's wrong with me. It's just stop it. And before around 3 weeks ago, It was again and again. I need to go toilet. Then I went to then after that now again stop suddenly. I don't know what could be the problem.
Okay. Did this when did it started exactly? 3 weeks ago?
No, 3 weeks ago it was again and again I go toilet, means frequently I go toilet. But after that I went to my doctor and he gave me medicine, and after it's fine, then now totally stop something, I don't know.
Okay. Do you have like urgent when you are passing urine? You cannot reach the toilet?
No. Now I go to toilet, I have swelling in tummy, I cannot pass urine this time.
Okay, so for how long did for how long you didn't pass the urine?
For X-ray, for lab,
For the last few hours.
Few hours only. Okay. Okay. So, are you taking any medication?
And doctor, I said I went to GP 3 weeks ago. I had again and again toilet. I go, means I cannot control, and GP give me my medication, and after that it's like urine going to be stopped, but condition worse now, and now swelling in my tummy and I cannot go washing.
Okay, sorry for hearing that. Okay. Just any other associated symptoms with this is retention?
Does pain, doctor, sometimes is uncomfortable swelling.
Okay. When you was passing with the urine, was including any blood, anything?
No.
Okay. Do you have any dribbling in the urination before?
Dribbling? Yeah.
Yeah. Okay. Okay. So, do you complete your bladder? I mean, you can pass full bladder?
Yeah, I cannot.
You cannot. Okay. Okay. So, do you have any fever?
No.
Okay. Do you have any past medical history?
Yes, this problem, I go again and again toilet. Only this.
Oh, yeah. Okay. So, do you smoker? Do you smoke?
Yes.
Okay. How many cigarettes per day?
10.
10 only. Okay. So, are you taking alcohol?
Yeah.
Okay. So, how many units? Sorry.
5 units per week.
Okay. So, you are taking any, illicit drug?
No.
Okay. So, do you have any past surgical history?
No.
Okay. Are you allergic from any medicine?
No.
Okay. You have any family history, family disease running in your family?
No.
Okay. According to your data, what is your concern, Mr. Ryan?
Doctor, what's wrong with me? I don't know.
Yeah, okay. So according to your data you have it now, and you told me this already, it happened before, most probably you have enlargement in your prostate, okay? So I'm going just to take you to the resuscitation room, and I will take your vital sign, and I'm going to just treat it you because already for a few hours you didn't pass urine. I'm going to put the catheter for you, okay? We have a score. It's called what's that? It score. Okay, according to that score, we will just manage you. I will see you after the catheter. If you are passing and you are doing good, it's okay. We have another line also for treatment. It is medication. We are going also to give you some medication for your treating your problem. And later you need sure to know how to. I will send you for continence nails. That way, she will learn you how to put catheter if you need it. Maybe this one it can happen again. Okay. If the medical management it fails, it may need for surgery later. Okay, that when it will decide it by your registry. That I will arrange for you appointment later. Did you
Okay.
understand my plan, Mr. Ryan?
Yeah, thank you.
Okay, welcome. Do you have any question?
No.
Okay, I hope to be fine.
Yeah. Guys, what could be the cause of this this pain condition? 68 and Ryan. What could be the cause of this patient?
Maybe medication, doctor. I miss
BPH?
And this,
BPH?
the patient, I said about the medication, right?
Medication, yeah.
Anticholinergic. Anticholinergic. This I said 3 weeks ago. I said 3 weeks ago, I need to go toilet again and again. Means overactive bladder. I also said in the words directly. And since then, I went to GP and he gave me medication. It's going fine, but this time today it's worse. That means this is due to the anticholinergic. Clear? So
yeah,
just pass the catheter and change the medication, stop the medication, you are fine. Nothing to do with the BPH here.
Okay.
Okay? Because this is due to medication. If I don't give you a history of medication, then you go for the BPH, put the first cause. So the lower urinary tract obstruction is most common advanced age BPH and the drugs. Okay, a patient give you history of drugs. I put in before you go for the drug history, even you didn't ask me the drug history, please try to make sure that you follow the approach nicely. You mix up the system and you didn't go very well. You didn't even ask me the drug history in after past medical history. So this, you guys are doing big mistakes. So it's okay, no problem. It's your first or second webinar, so you need to practice. So what I want to say, so this time I go how you want to go, means make everything simple for you. But when we will practice again these stations, if we got time, that time will be very complex. Maybe I will make these stations more complex that you even need to dig out all information. Now, when you ask me, can you please tell me more about that? I tell you everything from the beginning that what could be. So this can come up in your mind. Anyway, no problem. Practice will make you perfect. So in this case, the patient has medical due to medication. Just need to stop medication and pass relieve his symptoms with pass the catheter. Okay, and you don't need to pass the catheter before taking history. It's not necessary. You can go in the end. To sometimes maybe if he had a trauma, will you go for a catheter? Of course not. Okay, you will go for examination. Maybe urothermatus, there is a bleeding. Will you pass the catheter? No. So don't go for the directly catheter before you take in complete history. Try to take complete history, make sure. Then this is a medical cause, then go for catheterization, whatever you go. And treat the cause. Clear?
Yeah.
Yes, clear.
Okay, good try, guys. You must watch the videos which I already posted. So make sure that you should fingertips, you know the approach. Approach when you got it, the other things by time you will get it. And always, we already discussed these all, what are the causative. Already mentioned in the table. I will put the video, take the screenshot, or take the picture of the table to check what condition could be. You just memorize a few things. It's not really a big deal. Okay. Next one, who wants to practice? I hope there is any station.
I would like to.
Okay, thank you. So, oh no.
Next time.
If you want to go practice another station, which are here, so it's up to you. If you want to, you can.
Which site is it? Where are the stations?
Palpitation is a station. There are many stations. The same station with different, I mean, I will give you different, the diagnosis. You want to do palpitation? Is that okay?
Okay, sir.
Okay. Just give me 1 second. Okay.
Okay. Hello, I'm Dr. Maria. I'm the ED registrar on the floor today. Can I please confirm your name and age?
Well, I'm Amanda. I'm 27.
Oh, nice to meet you. Okay, so what has brought you to the ED today?
Yeah, doctor, I have a problem. I feel like my heart is going away. It's beating very fast.
I'm really sorry to hear that. Can you please elaborate a little bit more about that?
Yeah, it's started around 5 days ago. Before I don't feel that, but since then I feel really uncomfortable. When I'm walking and moving, I feel like my heart is just want to leave me alone, get out of from my chest.
Okay. And did it start suddenly or gradually?
I think it's suddenly.
5 days back, suddenly started. And how bad is it? Can you please score the intensity of your feeling from 1 to 10?
I think it could be 7.
Okay. And is it getting worse or better with time?
I feel it's the same, or maybe not going better, I would say.
Okay. Can you tell if there is something which makes it worse?
No clue, doctor, no clue.
And do you feel that there's something which makes it better?
No idea.
Okay. Is there anything associated with this feeling that you are experiencing? Anything else?
Recently, I noticed from last 10 days is like I feel a little bit anxious, or maybe I get angry quickly. I feel also hot, like I feel not normal. I feel like something goes wrong.
Okay, okay. And what do you think is the cause of symptoms? Do you have any ideas about that?
No clue.
Okay. And is there something that's making you worried? What is your basic concern over here?
I think maybe I'm going to soon have a heart attack.
Okay, don't worry, we'll handle that, don't worry. Okay, I would like to ask a few more questions. Can you please explain that? Do you have chest pain with it?
No, there is no pain. I don't feel pain.
Have you felt dizzy? Have you felt dizziness?
I cannot say anything about that.
Okay. Okay, have you experienced shortness of breath with it?
No.
Are you experiencing any cough or any sputum?
No.
Have you experienced any headache or vision problems?
Kind of headache, yeah. I feel a little bit headache, yeah.
Headache is with the palpitations.
Headache is, I work, I have so much work to do, yeah. So maybe because of my work, I don't know.
All right, all right. Have you noticed any rash or skin changes in your body recently?
No.
Have you experienced any fever or night sweats?
Yeah, I feel hot and sweating most of the time.
Since 5 days?
No, since 10 days. 5 days I am
Okay.
having this heart racing. The last 10 days I
Okay.
feel like not good. Yeah.
Have you lost any weight?
I found my trousers a little bit loose, maybe.
In past, how many days have you experienced that? In past 1 month, 2 months? How long?
I cannot say any, but yesterday I tried my trouser, which always fits on me, and I put on and I found that it cannot put on. It's look loose.
Okay, so, and how is your appetite?
Feel hungry.
You're very hungry.
I think
Okay.
it's okay, not really a big problem. Yeah.
Okay. And have you experienced any changes in your urine color or frequency?
No.
Okay. Have you experienced any changes in your bowel movements? Like you have to go to washroom more often for passing stool?
No, I cannot say, but I feel like something goes not right. Is sometime bloating, maybe it's like I would say not normal as usual.
Okay. Are your periods normal or are they also disturbed?
I found some change in blood color. It's a little bit lighter, I would say.
The period is lighter. And is the cycle regular or irregular?
I think it's for now it's regular.
Okay, otherwise it has been around a few days, few cycles.
Dr. Nikolai, I just noticed the color, the changes
Okay,
a little
okay.
lighter.
Have you been experiencing body weakness or numbness?
Well, I think fatigue sometime. Not really. We didn't say anything about that.
Okay, okay. Can you please tell me, do you have any known illness, like do you have diabetes or hypertension or known heart problem?
Other than the problem which I'm having, no.
Okay. And are you taking any medicines currently?
No.
Okay. Have you had any surgery in the past?
No.
Can you please know what you do for a living?
I'm a computer programmer.
All right, all right. I'm sorry for the next question, but do you use alcohol?
Sometimes. No.
Yeah. Have you, by any chance, used any illicit drugs?
No.
Okay. Do you smoke?
Sometimes.
All right, all right. So let me summarize to you what and you will tell me if I say anything wrong. Okay, please correct me if I say anything wrong. You have been experiencing palpitations from last 5 days, and from past 10 days you have also felt hot, and you have experienced some kind of weight loss, and you are also experiencing bloating. And when you experience the palpitation, it makes you feel very anxious. And I think that's all that you've been experiencing, or am I missing something?
Yeah, that's correct.
All right. From the things that I've gathered from the history, most probably you have the problem with your thyroid gland. It's the gland in your throat which have a lot of hormonal control, which controls the body in many ways. Now, to get to the correct diagnosis, It can also be a heart problem too. So for that, first of all, I will have to examine you thoroughly. I will also have to examine your thyroid gland, and I will take a ECG tracing of your heart, tracing of your heart. It's called ECG, and then I will also have to take some blood tests to test the level of hormones which this thyroid gland, which I'm talking about, produces. And the results of this blood test will tell us whether you have a thyroid problem or not. And based on those tests, I will be giving you, if it turns out to be a thyroid problem, then I will be giving you some medicines which will basically, they will cause radioablation of the gland. Basically, they will control the problem. There are three kinds of plan that I can give you. I can give you medicines which will cause the radioablation of the gland, or I can give you anti-thyroid drugs. And the third problem, the third treatment that can be offered to you is surgery, which can be thyroidectomy. If it turns out to be a problem with the heart, then the treatment will be different. If it something that I am thinking of, it that it can be SVT, but that can only be confirmed with the ECG, the tracing of your heart. If it turns out to be SVT, then I will be doing. Sir, can I ask a question? Do you know this? Oski, do I have to be in management of both my DDs?
No, you don't need to go for SVT. Okay, well done.
Do you have any questions?
No, well done, Doctor. Doctor name is Mariam, right?
Mariam.
Okay, well done. You did great, but please, this clinical picture is very, very clear with the thyrotoxicosis. Okay, so you could say the high or increased amount of hormone is releasing in your body, or the more simplified, there is a gland in your neck, in front of your neck, called thyroid gland. Well, the management plan is good, but you don't need to say, I will give you, no. You need to say, we have 3 management plan, because the radioactive ID, you cannot do nothing because it's done by the nuclear medicine, right? Not you. Okay, so you just give the 3 management plan. You just tell her. And if she doesn't agree, then the medical treatment you can give, of course, and you will arrange a follow-up with endocrinology. Well done, you follow the approach, but you still need to improve it, okay? Still need to work.
Thank you, sir.
Okay, all right,
Yes,
so you did a great job. Okay, guys, thank you very much. This was our last station. Thank you for coming. I think you guys, everyone has learned something, and please, please, these tables all give you a clue what station would be, because I make these all cases from these stations which already we discussed. I give you 15 minutes because I want you use your 15 minutes to set out your plan for the practice. Try to follow approach, and approach will come up with your concentration, not mine. I can correct you with the approach as well, but you know, if you forget one system, I can correct you. But if you forget 3, 4 systems, I cannot correct you all the systems. Okay, so try to focus, make your approach smoothly on fingertips. Then if you forget 1, 2 systems, I will note it out and I will remind you. But if you go mix up all things, like you don't go for ODPARA, you start systemic and then ODPARA again, you're making everything complex. This I don't have even time or even choice to correct you. So don't do that, because these things are already available in video. You can just take a photo, guys, take photo, or just write down on your paper, this is approach done, then condition. Thyrotoxicity, what is the minimum? This is common station. SVT, older adults like can come up ventricular tachycardia, which is very rare to come up. AFib can come up to young patient, indifferent from paroxysmal, persistent, can be permanent, but the treatment all the same, beta blocker first line. So these things you try to, sometimes you need to focus. You don't need to take the OSCE very light. Believe me, OSCE would be even nightmare for you if you just take it easy. It's even worse than intermediate in some cases. I don't scare you, but I want you should alert and be active. About the India diet and Malaysia diet, some people said the passing rate is high. I agree with you. The reason are few reasons. The important reason I want to focus, very, very important reason that nobody knows it. The reason is problem is that India and the Malaysia diet, there are some doctors go in those countries and they give them live session. When they got the live session, the people know each other, right? For example, I have my friend like Jason. He went to the morning exam and the next day I have the exam. So he told me the station, right? That's why the passing rate is high. In London, it's not the case like that. Not everyone can tell, even people scared to tell. And now the RCAM changed there are modification in the result. For example, before they do on the same day what is the calculation, what is the closing, but now they want to do it entirely. First, don't tell to others. Second, if you cotton, you will be banned. So need to take, be careful, prepare. This is not very difficult, to be honest. Station will be the same, everything will be same, just you need to focus. And I already make simplified many things for you. Scores I'm highlighting. You can do Google by yourself. Guidelines I'm putting up. Tell you the management plane. What's left? You just need to prepare for approach. You're done. Any station come up with you, you know the disease, you can just make it management, you just make it simplified. That's it. History is done. I will come up with this week. Today is Thursday, right? I will try to give you next webinar on Sunday, but this will be sexual history, and I will include the other some part which are bleeding. We didn't aid the station of bleeding, so I will try to aid the bleeding these stations. So we'll come up with the next webinar. I will try to give you on Sunday, and this will be again very important webinar. Last time a station came from DAS, which we will discuss on Sunday. Please go with the approach, check it out, and let me know. If you have any difficulty, you can reach me. Some people are reaching me in a private. I try to help you as much as I can, but I'm very busy, so sometimes I cannot reply you. Please forgive me. So any question, guys?
Thank you very much. I appreciate this is a very good session. Just I have a question. If I want to take my exam in India, so should I consider myself or should I consider the patient in UK? That means regarding the travel history or something like that. Do you understand my question?
Oh, your mean is that when you were in the India, and better to consider as a UK, because you are going to give exam of work in the UK, not in India, right? The MRCEM come from UK, not from India, so you will work in the UK, right? After MRCEM, so you need to consider the old history or anything approach you're following is according to UK. Clear?
Yeah, yes, regarding the patient in front of me, that means I consider this patient in UK.
Yes.
If I ask him about the traveling history like that.
Yes,
yeah.
you need to, because this exam conducted by the UK and you are going to work in the UK, so you should have knowledge about the UK, not for the India, right? You will not work in India, obviously. So the conduction anywhere in the world, no problem, but make sure the exam is the UK, so everything you will be asked according to the UK guidelines, the approach of the UK. Okay, anybody? Any question, guys?
Thank you, Dr. B. It's very useful. God bless you.
Yeah, doctor, I want to ask you, thank you very much. First of all, you are so patient to us, and you are teaching and repeatedly correcting our mistakes. Thank you. Just for the pain relief, that if the patient has shortness of breath case scenario or palpitation, there is no pain linked with it, but still we will ask.
Yeah, you can ask this question. For example, someone said, I don't feel comfortable, like heart raising. So after that, you should say empathy. I'm sorry to hear that. Are you comfortable? But that's it. Are you comfortable? Are you in a pain or any discomfort? Just if you ask, are you comfortable? That means she's okay. Just go for further. If you want to eat it. Got it. It's include everything. Are you comfortable means pain, any discomfort, anything, all are included. Clear?
Yes, sir. Thank you very much.
Okay. Any other question, guys? No?
I have one question first, right?
Yeah.
Okay, regarding sexual experience here, if the partner, the wife, for example, she's who's the one he have to inform the partner, the wife, I mean, or husband, if one of them is sexual transmitter.
You are talking of a sexual history. We will come up with the webinar and we will discuss. I think so. You're probably clear. Okay.
Okay.
Hopefully,
Yeah, okay, doctor.
hope
Okay, thank
everything.
you.
If everything goes fine, we will come up with the bleeding. Okay, we will come up the bleeding and also sexual history together on Sunday. Hopefully, if I think I will have off day, I will try to get with you guys. Okay, thank you very much for coming. Thank you for joining, guys, and have a nice evening. Stay blessed.
Thank you, sir. So kind of.
Thank you very much. Thank you very much.